Hi guys, how's everybody doing? This is the last spinal anatomy lecture. It is Wednesday. It is week 10. It is spring 2020. And let's do it. It's not even a super long lecture, but it is on biomechanics. So let's go through biomechanics. So in order to be a true spine expert, you need to understand a little bit about biomechanics of the spine. And therefore, we need to talk about biomechanical planes of motion. And the terminology is different than what you're going to use most of the time in clinical practice. Most of the time, you just talk about flexion extension of the lumbar spine or flexion extension of the cervical spine, rotation of these regions of the spine, lateral bending or side bending. That's what you're going to be talking about. You have to memorize the degrees, and you'll find out different ways. There's ways to measure. Thoracic has a range of motion. You have to use a dual digital inclinometer. If you do work comp in California, you have to become familiar with that. I don't think they teach that in a school. But if you're a biomechanist, then you need to know a little bit about this too, because like anterior translation of a spondylolisthesis, there could be sagittal translational instability. What if it says that on your X-ray report or on your MRI report or your X-ray report? You need to know what that means. So let's go through some of this stuff. And it's kind of easy in a way because really there's only two general planes of motion that a vertebrae can undergo. And that's translation. Let's draw translation down here. And these motions apply to a motion segment, which of course is a vertebrae disc, vertebrae sandwich. And we'll view this one. And they have different views. Some you view from the lateral, some you view from overhead, some you view from A to P. But for translations, we'll look at sagittal anterior and posterior translation. The top vertebrae slides forward, or it slides backwards on the vertebrae below. And that is translation, one form of sagittal anterior to posterior translation. You can also have translation sliding up and down. All right? It's not rotation. The points on this vertebrae are not spinning. All the points on this vertebrae are moving in the same direction. So that's a translation, and we'll go through the different types. Rotation is if the vertebrae, if the top vertebrae tips up. We'll leave this one down here. So this vertebrae has tipped upwards, or it can tip backwards from the sagittal view again. We'll use. Okay, so that's a rotation. That's going to have a central point of rotation. The points are going to move differently depending where the points are on the vertebrae. But that's also a form. So there's only two types, translation and rotation. Right? And the other concept you have to, if you've had math, higher degrees of math, you understand this already. There are three planes of motion that translation and rotation can occur around. And that's the old X and Y axis and a new one called the Z axis. Well, not new. If you've had advanced math, you know what the Z axis is. But X and Y have been around probably since grade school nowadays. So you can have a rotation around the Y axis. You can have a translation around the Y axis, and etc. So that's kind of where we're going from this stuff. And just here's a cartoon. And in this cartoon, the y-axis is running up and down. The x-axis is running side to side. And this is kind of going deep into the plane of the page. Picture it going and disappearing. So this is going from posterior to anterior. That would be the z-axis. And we'll talk about those more in a minute, but let's cover some other stuff. So again, translational motion occurs when a force pushes a vertebrae in a way that makes all the points on that vertebrae move in the same plane and in the same direction. So if we have a block sitting on a floor, a plywood, straight piece of plywood, and we push the block forward, no matter what point you pick, and let's say we push it the force is only going to move at a 1/2 inch. Every single point on this vertebrae, no matter where I measure it from, will move 1/2 inch. And they'll all be in the same plane and all be in the same direction. Okay, so they move the same distance. I could add same direction, and I could add a distance in here if I wanted to. And yeah, and such unidirectional movement is called translation. Even if we have 2 forces, as long as the forces are exactly in the same way, or 3 forces, as long as the forces are going exactly the same plane, exactly the same direction, you're going to create a translational motion. All right? It also creates, as we drag this block forward, it's going to, let's see if I remember how to do this, pointer option. Oh, I messed it up. Let's see. It's going to create a drag right here, right? And that's going to cause energy. That can even get hot, and that's a frictional force. And that force is called shear force. Shear force. Why? Because the vertebrae drags across the surface and creates there's some resistance, and energy is needed, and that is in the form of heat in some circumstances. But the key is it's a shear force. We've talked about already patients with a hyperlordosis, how that creates a shear force on L5 in particular, and L4, as they want to slide down their bodies. And that, remember this picture? So here is Ferguson's line, drawn down from the 3rd vertebrae, drop it straight down, perpendicular to the earth. And yeah, the line should be passing right through the anterior portion of the sacrum. Right, there's S1. And it's not, it's way out here. So that creates a shear right here on the L5 disc, which can blow that disc out or rip it. And it also creates increased pressure on the pars interarticularis, and you can fracture like this person did, right? This person has fractured. Right? And you can see the fracture right through here. And you can see the slip, right? It looks to me like it's past 25%, or real close to a grade 2 spondylolisthesis. All right? So the other general biomechanical movement is called rotation. And this one's a little different. Instead of having 2 forces pushing the same direction, they don't even have to be the same magnitude in that scenario. But if you have 2 forces pushing in different directions, now we're not going to slide that block around down on the pavement here. It's going to put or impart a rotational force into it. So here we have force 1 pushing this way. We have force 2 pushing that way, and it's going to cause this thing to spin. Right? And that's a rotational movement. The distance on the points can be different too, right? If we allow this to rotate only a 1/2 inch and measure the distance and pick a couple points like this point and this point, if we rotate a 1/2 inch, I mean, we have a heck of a lot more movement here. It's not all the points that you choose have different movements, and they don't move in a straight line on the same plane like the last one did. These move in what's called an arc. Okay? So coupled force and torque. So these 2 forces sometimes are called coupled when you have 2 forces going in a different direction applied on an object and they cause it to rotate. You can add those forces, but those are coupled forces. That's all I'll say about that. There's also one point on the body, or maybe this is the humerus or a vertebral body, but there's one point that you can choose on the object that's rotating that will have 0 arc, or 0 movement. And that's called the center of rotation. The center of rotation. The net force of the coupled force, that makes up something called torque. And I won't go crazy into torque because it's kind of a complicated subject, but we'll talk about it a tiny bit. So results from the actions of two opposing forces that are generated in the body by different muscular actions. There can also be one force, a pushing force, and one force that's stationary, like a muscle moving something, a bone, and a ligament resisting that motion can cause a twisting of that bone or that point or whatever you are looking at. So it doesn't always have to be two forces. It could be one force and one resisting force, like a zero force, but it's still resisting. That can still cause a rotation, which can cause a torque. Gravity, for example, can oppose. It opposes your cheeks. You feel your cheeks. Gravity is pulling those things down, but that force can be resisted by the type 1 collagen makeup of your cheeks and of the muscles under there, zygomaticus muscles. All right, and then when a straight line, or like when a bone rotates perfectly, we have different points on the bone have different excursions, or rotational excursions just means like this point is going to move a heck of a lot further than this little point down here when you rotate. So you have different amount of rotational excursions. But nevertheless, all these points rotate in the same plane, but they don't rotate. Their arcs are different measures. Assuming you don't put the point, like if I chose a point here and a point here, equal distance away from the center of rotation, they're going to rotate. Their arc will be the same. But if I choose one out here and one out here, the rotations are going to be way different. The axis of rotation, that's just that center that has no arc. So the definition is the region in an object or bone that does not move when two or more opposing unaligned forces act upon it. It causes a rotation. Right? So basically it's the spot in these planes that has no movement. Also, the axis of rotation will be perpendicular 90 degrees to the plane of rotation. Right? All right, that was kind of dry. Sorry about that. But now this is a little more exciting, at least, because we'll show you how this kind of relates clinically as well. Planes of motion. So before we even start this, remember the anatomical position of the body. This is the anatomical position of the body, right? It's standing, looking straight ahead, and that will give us our laterals will be here. Anterior will be out of the plane of the page. Posterior will be behind the plane of the page. The hands, the palms will be facing forward. That is the anatomical position. And the anatomical position of the vertebrae is looking straight at it from an A to P view. Transverse processes will be sticking out here. Spinous process will be kind of in the plane of the page in the back. And yeah, that's the anatomical position of the vertebrae from an A to P perspective. Right, so here's two typical cervical vertebrae. There's a motion segment. They're in the anatomical position. We're looking straight at them. You could go from behind and there'd be an anatomical position, but this is what we're talking about. Okay. Biomechanical planes of motion. So movements generally occur in several directions. And they oppose. There'll be a forward movement and a backwards movement. There'll be a sideways to the right or sideways to the left. There'll be an up movement. There'll be a down movement. There'll be a twisting to the right, twisting in the left. Sorry about that. Three biomechanical axes. We talked about them, but let's look a little closer at these three biomechanical axes. There's an X, a Y, and a Z axis. That's the same picture, just a little more filled in. Now you can see this is a cube, and this can play tricks on you too. But pretend this is at the back side of somebody, so it's kind of an oblique-ish view. This is posterior. Anterior is covered up. You can't see the anterior surface. See, anterior, then I made it real light there. This is the left lateral surface. The right lateral surface you can't see that either. we can see the entire inferior surface. The superior surface we can't see at all. But if you take a block, which could be a vertebral body, I mean, we could have transverse processes sticking out of it. I'll show you that in a minute. But we have the transverse processes would be running in the x-axis plane. The spine actually runs up and down. That would be the y-axis. And then if you stick your tongue out, stick your tongue straight out of your mouth. I just did it. Stick your tongue out of your mouth. That's the z-axis. That's the front and back. The A to P, P to A axis would be that. Okay. If we superimpose that on a bone, which might have been easier to start with, because we're familiar with the bone, again from transverse process, this is a lumbar vertebrae with the transverse processes sticking straight out. Moving on that plane, that's the x-axis. Moving up and down the spine, or compressing the spine down, or tractioning the spine up, that's the y-axis. And moving front to back, that would be the z-axis. Right? I won't get into these pluses, but just to at least tell you about them, a plus x translation means a translation to the left, and a minus x would be over here. Plus z would mean the movement is heading toward the front. A minus z means the movement of the bone, or the translation of the bone is heading toward the back. And if you distract upward, that's a plus y translation. And if you compress downward, that's a negative y translation. Just to say, I'm not going to test you on that, but just wanted you to be familiar with that. Maybe some of you are really going into this stuff. Translations, again, as mentioned before, there's only two general types of biomechanical movement. There are the translations. And when you think of translation, just think of a sliding, like a kid sliding down a hill in the snow, or the kid kind of, well, it's a little, I shouldn't say that, a kid rolling across the ground with a skateboard. I mean, the wheels are rotating, so we have a rotation. But the movement, it's better to picture a kid pushing a box across the street. That's a translational movement. All the movement occurs in one plane, and the object moving it doesn't rotate. It all goes in the same direction. And then a rotation, so these translations can go in all these different planes. So you can slide the bone, but the bone does not rotate. You can pull the bone straight up along this axis, push the bone. Without moving the bone is frozen. But you can slide it along these axes. You can slide it to the side, either side. And then you can slide it forward and slide it backwards. But you can't rotate it at all, because that's not a translation. That's a rotation. You can also rotate the bone around these sticks. So we can rotate around the y-axis. I mean, what's that? That's rotation. We can rotate around the x-axis. What's that? That's flexion. If you rotate it the other direction, that's extension. Okay, and then we can rotate it around the z-axis. What's that? That's lateral bending. See how that works, and we'll expand on that. All right, so let's meet the biomechanical movements of the motion segment. So let's start out with sagittal translation. So there's an anterior and there's a posterior sagittal translation, right? The thing about sagittal translation is, to view sagittal translation, you have to view it from the side, from a lateral view, or you want to look at the sagittal plane. So that's important to kind of keep these straight in your mind, is what view you need to take to see this stuff happens. Okay, so this is the example that I drew already. So it's going to slide around the z-axis, right? So we're going to move this whole vertebrae over this way, but we're sliding it in this axis. I guess I always have this in my slides, so no sense in drawing it again. But we're going to slide it along the z-axis. Oh, I'm sorry, I just showed you along the x-axis. This is along the z-axis. That's how this type of translation. A to P translation is along the z-axis. I better make that right. It's along this axis right here. that we're sliding forward or we're sliding back. And this is clinically significant. All right? If you slide forward, that's an anterior sagittal translation. You need to know that. That's an anterior. If you slide in the z-axis forward, that's basically pushing one motion segment forward in relation to the other without twisting either one of them. That's an anterior sagittal translation. Some people just call it, when you get in practice, it's a slip. It's a forward slip. That's kind of the slang name for it, a forward slip. But that's an anterior sagittal translation. Posterior sagittal translation is a backward slip or a backward slide or a backwards glide. Can I add slip? Maybe I'll make a note here to do that. 24, add slip in there, because that's how many clinicians talk about these slips. All right, so now here's the better drawing. So an anterior sagittal translation, which is viewed, I remember it's sagittal because we're viewing the sagittal plane. An anterior sagittal translation goes like this. The bones don't twist. The bone on the bottom doesn't matter, doesn't move. It's just a plane that this can translate over. Posterior sagittal translation goes back like that. Okay, the movement is best observed from a lateral direction or by looking at the sagittal plane. Right? Definitely excessive sagittal translation is a well-known cause of chronic spine pain. In fact, there's measures. That's one of the things you always do. A lot of docs forget to do that. Flexion extension study, you measure how much translational slip is there, how much sagittal translation is there. You compare the anterior to the posterior sagittal translation. It better not be more than 3 millimeters, or you got yourself a problem. You go more than 5 millimeters, you're going to have surgery for that. How does sagittal plane or sagittal translation occur in the spine? One way you could push, right? You could just go, I could take my finger and I could push forward on this bone. That would cause, or at least try to cause, an anterior sagittal translation. But aside from pushing, is there another way that you could impart a sagittal translational force? And the answer is yes. When you bend forward at the waist and bend backwards, those are called sagittal rotations. Sagittal anterior rotation, sagittal posterior rotation. That's going to be around the x-axis is where the rotation is going to occur. But that force, it will impart a sagittal translational force as well. All right. So every time you bend forward, your bone, your motion segments have a tendency to want to slip forward. When you bend backwards, they have a tendency to want to slip backwards. And it could be vice versa. Sometimes some people, when they bend forward, their bone slides forward. Some people bend backwards and the bone slides backwards. It's not always one direction. It could be either direction. But nevertheless, there is a sagittal translational force caused when you bend forward and bend backwards. In biomechanical speak, there's a sagittal translational force imparted on the motion segment when you sagittally rotate forward and sagittally rotate backwards. Got that? Understand that? So these two forces, sagittal translation and sagittal rotation, are coupled forces. One force invokes the other, or it tries to invoke the other. Luckily, we have Z joints, right? Normally, if the ligaments and the Z joints and neural arch are intact and solid, there will be no sagittal translation, or very, very little. But if you have a fracture through the posterior arch or neural arch at pars interarticularis and you bend forward, you might get some slip. You might get a lot of slip there. Anything over 3.5 millimeters is of total sagittal translation is abnormal. Anything under is considered normal, even though some people have 2 millimeters or so of motion, and that could be a pain generator depending on the health of their facet joints. So here's kind of a motion study. So here's a motion segment. Notice when it's in place, these two dots line up really nice. But when this patient bends forward, this bone doesn't do anything, but this bone slides way out here. Or now we could say it sagittally translates. In fact, we can measure the sagittal translation, and it is about 7 millimeters. And see the rotational component, see the arc here? So it's not pure sagittal translation, really. That's because these two motions, sagittal translation and sagittal rotation, are coupled. But nevertheless, that ain't good. This person's going to have spine fusion if the oswestry is high enough. Usually over 50 is the number I use. But yeah, so that we have clinical examples of that all the time. In fact, let's do a case. 52-year-old female, true story, comes in. She has chronic low back pain from India. Bilateral extremity pain, absolutely miserable, unable to work. She failed all conservative care. I don't know if it's fair to say it's a third world surgeon, but not the smartest move, in my opinion. The surgeon in this country said, no, there's nothing you can do. You have to live with this pain for the rest of your life. You can go on disability. But they forgot to order the simplest of tests. The surgeon said, no, you're not a candidate for surgery. But they forgot to order flexion extension radiograph because we got to make sure the patient is stable. And here's the actual patient's movements. So this is extension, and I twisted the x-rays around so we can compare apples to apples. I'm able to spin these in my software program. But when she goes backwards, the bone squirts way out. Right? Here's L5. And look how far the back of it. It's way out here. Right? It should be back here. Here's S1. See how it squirted? It squirted 80.85 centimeters. All right? Then, when we flexed her forward, if this would have stayed put, she would have been stable, but it didn't. It slid all the way back here. Right? So they're almost, now it's down to 0.16 centimeters. Or you could say 1.6 millimeters, and this was 8.5 millimeters. I usually work in millimeters more. So if you subtract these distances, you get the excursion. How much is she slipping and sliding? So she's sliding almost 7 millimeters back and forth. And can you imagine doing the activities of daily living, making the bed and doing the wash and making the dinner and picking up the dog and picking up kids? I mean, this thing is banging back and forth all day. It's going to bang the nerve roots, cause sciatica. If there's an annular tear in this disc, it's going to irritate that. If the facet joints are wrecked, it's going to irritate those. So this is clinically significant. And she ended up flying to Germany and had a inner body fusion and was doing really well. Her oswestry dropped down to 22, and that's able to get back to work, and not perfect, but that's an average outcome. That's actually a tiny bit better than average outcome with regard to inner body fusion. Not everybody gets 100% better like Tiger Woods did with his anterior inner body fusion. And for all those haters of fusion out there, and there's a lot of them, that fusion is the devil's work. It can be a lifesaver, and the point is Tiger Woods. I mean, he won the Masters after having some failed other silly surgeries, laser surgeries, all this silly stuff. Yeah, I don't recommend doing what he's doing. I think eventually he's going to blow the disc out above, and that's going to be the end of it. But anyway, let's not go down that pathway. All right, how about horizontal translation? So what's horizontal? Got to know this, right? HAT. AKAs for horizontal axial. And this is going to get us in trouble here in a minute, in a little bit. Transverse, you could even make it chat, cross-sectional, but we really don't use that in radiography at all or biomechanics. So HAT. Horizontal, that's an overhead look, right? Where our eyeballs are up here, we're looking down. It's an overhead view. All right, so there is a horizontal sliding. So take a guess what axis it has to be around. What axis do you think? Well, from a horizontal translation, that's when the vertebrae slides along the horizontal plane laterally. So we're sliding across the x-axis. I mean, really, we could see the z-axis as well, but this, you just have to memorize this. In a horizontal bird's eye view is used to see lateral movement only. I always think if you're looking down the stack of a vertebrae and there's one vertebrae slides out laterally, you'll be able to see it. It'll stick out like a sore thumb. That'll be a good way to look at it. In reality, we could see it from the A to P view slide laterally. We could also see it. I mean, you can kind of see it even from the lateral view. But remember, horizontal view is where you see the lateral slip. Okay? So there is a left and right horizontal translation from the bird's eye view. And again, this movement is viewed best from an overhead perspective. In biomechanical speak, it is a translation along the x-axis to the right or left. Okay, and by convention, as I mentioned, when it slips to the left, that's a plus x, slips to the right, it's a minus x. Left horizontal translation is also called left lateral slide, right? Because remember, slide, we're sliding, we're translating. Right horizontal translation can be called right lateral slide. Right, here's a picture, but really we should be looking from up. It's a bird's eye view of this. And if you look down at it, you see the slip along the x-axis. There's a right horizontal translation, or x negative, and there is a left horizontal translation, or an x positive. Got it? Is there a horizontal translational instability? Everybody forgets about this, and it does. Sometimes it does carry some clinical weight. Matter of fact, yesterday I had a scoliosis patient who had a lateral listhesis. Don't know if it was unstable yet. I had to order a lateral bending x-ray study to see if she's unstable in this horizontal translational plane. I mean, she's probably going to need fusion anyway, but that's good information to tell the surgeon. Right, so scoliosis patients who have hyperlordotic lumbar spines are at risk for this. And just like with a sagittal translational instability, the front and back slip, patients can have a horizontal translational instability, and that can result in chronic pain, or you could say a lateral slip. All right, 22-year-old female with chronic low back pain in the lower thoracic spine and lumbar spine, some pain in this region. You can see, right? Got one shoulder a little higher than the other. We can see we got an Adams sign if she would bend forward. Scapula, she's got a wicked scoliosis. In fact, we can see that scoliosis. Right? That's a pretty nasty scoliosis. Is there a way to straighten that? Not manually. There's no chiropractic treatment or physical therapy in the world that can straighten that thing out, despite what YouTube says. But there is a surgical procedure that can straighten that thing right out. Pretty darn good. Right? So that's an anterior intersegmental type of fusion approach. They call it anterior because it's addressing only the anterior columns, even though the surgery is done from the lateral side there. But yeah, pretty good outcome. All right, not perfect though, but definitely pretty good. So here's one of my patients, 54-year-old male, disabling low back pain, refractory, a recalcitrant. I look those words. Make sure you know these words. Add those to your vocabulary. Refractory, recalcitrant to conservative care. That means it was resistant. The conservative care doesn't work. What's conservative care? That's anything without poking through the skin. So chiropractic care, acupuncture, physical therapy. So none of that stuff work. So brought in the MRI, and here's an A to P view. You can see the psoas muscles, psoas major nicely. You can see the kidneys. How's that spine look? Looks just like the lady yesterday. Lady yesterday is worse. Yeah, pretty beat up, but what should catch your eye, I mean, you always look at the positioning of these blocks. I mean, these guys are all pretty much in place. But when we come down to here, I mean, that's ridiculous, right? That's called a lateral listhesis. And the question is, what happens when she bends to the right and bends to the left? Is this stable? Is this going to slip to here when she bends to the right and then slip out to here when she bends to the... I mean, if it's greater than 3.5 millimeters, right? Greater than 3.5 millimeters, she's unstable. It's greater than 4 or 5 millimeters. You're going to have surgery to stabilize that. All right, so the coronal demonstrated a severe left horizontal translation malposition of L3. In other words, in clinical speak, it's a lateral listhesis. So bending studies revealed that a lateral translational instability did exist, and it was greater than 3.5 millimeters, and she ended up having a fusion. I don't know the outcome on this one, though. Okay, so that's a lateral listhesis. All right, let's talk about a coronal translation. Coronal, where's that? Coronal is looking A to P, right? There's the little man, his legs standing here. This is why I don't draw on the board. I shouldn't draw anywhere. Eyes. So this is an anterior to posterior view or a posterior to anterior view. That's a coronal. This is the coronal plane. And so this coronal translation is best viewed in the coronal plane from the front, right? And this is the movement of a vertebrae up or down the y-axis. So in other words, it's a traction, right? So we're looking, here's an A to P view of two motion segments. And maybe this is cervical spine. And you pull on the patient's head and this vertebrae slides up to here. Okay, so that's a coronal translation. In fact, we can call it either a positive coronal translation or more specifically for our test, it's a cephalad coronal translation, meaning the bone was pulled toward the sky, toward the head. We can also have a caudal coronal translation or negative Y. And these is down, I mean, this is the y-axis right here, right? So you can push down on the patient's head and compress the vertebrae down, and that's a caudal coronal translation. All right? Sometimes these are called longitudinal or confusingly, really confusingly, axial distraction. It's a terrible word, yet they use it. Because axial is an AKA for hat, horizontal axial transverse. All right, but it's commonly known as a distraction, a longitudinal distraction, or a cervical distraction, or pulling up. And we do use this as a treatment modality. And you can do manual traction to someone's neck, and it makes it feel real good and can break muscle spasm, and it's a good treatment. The coronal, or the cephalad coronal translation is really not used. It's been replaced confusingly by cephalad axial translation or cephalad coronal translation. We don't really use it. They just call it axial translation or cephalad axial translation. Okay, there's some treatments like Cox treatment does this. So here's a perfect example. Okay, so this is a home traction unit. You can give these to your patients with neck herniated discs, and they can put water in here, and water has a certain weight, so they have the same force, and there's some little pulleys here, and we have a force pulling up on her head. That is, what type of force is that? Well, it's going toward the head, so it's a cephalad, and we always view in the coronal plane, so it's a coronal cephalad translation, or a positive coronal translational force, if you will. Or just a distraction force, a cephalad distraction force. In plain English, you're going to give them a cervical traction unit, and it's a cervical distraction, which is understood. It's in this y-axis here. Okay, so it's a translation along upwards, cephalad. I mean, this is her head, so how can it be cephalad? It's going up. You could call it superior, I guess, if you want. Superior coronal translation. Got it? Caudal coronal translation. So that, as we said, that's a movement of the vertebrae down the y-axis. We don't use this term. It's been replaced by caudal axial translation. Axial means, think of a pole sticking right through the neural foramen. That pole is an axial axis, I guess. But it's a terrible word because axial is an AKA for horizontal. So somebody doesn't know their AKAs when they invented this. So again, commonly known as longitudinal axial compression. It's usually a pushing down force, but it doesn't always have to be. There's a cross-tractional force. You can make an X with your hand, and one hand can push up and one hand can push down, and you can put a traction, kind of a cephalad and a caudal traction force on patients. So it's not always just a compression force. So you can put one hand, I'm not even going to try to draw it, but you can have one hand pushing this way and another pushing that way, and therefore we've imparted a cephalad coronal translation on this vertebrae and a caudal coronal translation on this vertebrae. And this is kind of called a cross-traction. Some people call it a decompression, although decompressions can be isolated to cephalad or isolated to caudal as well. All right, so here's the nice easy way. Let's there's the y-axis, and so if you pull up on a vertebrae, it puts a cephalad coronal translation. If you push down and move the vertebrae down, that's a caudal coronal translation. Are we good? You see why this is going to be a short lecture today? This is confusing stuff. It's going to take you a little while to get this in your brains. Sagittal rotation. So now we go back to the plane. We already know this is the one that was coupled, right? So there's an anterior and posterior sagittal, not translation. That was the slide. This is a twisting, rotation. What does that mean? This is bending forward at the waist and bending backward at the waist. So this movement is going to occur around the x-axis. An anterior sagittal rotation is forward bending. Posterior sagittal rotation is backwards bending or extension. Remember, we said the movement is coupled with sagittal translation. Sagittal rotation causes or tries to cause a sagittal translation of the superior member of the motion segment. Why do I say tries to cause? Because normally the posterior arch and facet joints will stop that translation. There will be no slip unless the posterior arch is broken or unless the facets are too sagittal in alignment and you can slip with a degenerative spondylolisthesis. All right, let's look at it. So this is bending forward. We're getting a rotation around the x-axis. And yeah, it's best visualized from the side view. So we're looking at the sagittal plane. So it's called a sagittal anterior rotation, sagittal posterior rotation. All right, or you could call it an anterior sagittal rotation or sagittal anterior rotation, either one. And there she's bending backwards, and we're getting the bone going like this as she bends backwards. Right? So that's rotating around the x-axis, best seen in the sagittal view, so it's a sagittal posterior rotation. Got it? Commonly known as bending backwards. Okay, got another one to do. What about coronal? Now we're back in that A to P plane again, the coronal rotation. So this time we have a left and right coronal rotation. So this is just lateral bending to the side, bending to the right, bending to the left, lateral bending. Only in biomechanical speak, you don't call it lateral bending. You call it right and left coronal rotation. Best visualized in the A to P view. So you need to look at the coronal plane. You got to remember that. I mean, in reality, we could see this kind of from overhead, and we can kind of see it from the lateral, the sagittal plane and the axial plane. But you have to remember, coronal plane is the best way to watch this. Right? The rotation is now going to occur around the z-axis. Bending to the left is z negative, bending to the right is z positive. Could be pathologically coupled with horizontal translation. Remember, we said that I always order the lateral bending studies to see if it can bring out a horizontal translational instability. And so these are also coupled, just like sagittal translation and sagittal rotation are coupled. So are these two motions. Okay, so there's just lateral bending to the side. So this spinous is tipping up, this one is tipping down. And this type of movement can't occur around the y-axis, can't occur around the x. It can only rotate around the z-axis. It could rotate smoothly there. So right and left lateral bending, biomechanical speak, right and left coronal rotation. How about horizontal rotation? All right, so we're going overhead again. So horizontal translation, we said, is lateral slip to the left or right. But there's also, from that horizontal view, we can look at a horizontal rotation. This is just rotating the trunk to the right, rotating the trunk to the left. It's twisting of the cervical spine, turning the head to the left, turning to the head to the right. In biomechanical speak, it's called horizontal rotation, right and left horizontal rotation. This is best viewed from the overhead view, which is overhead view looks at a horizontal plane. Commonly known as right and left axial rotation. So this one works okay because axial is AKA for horizontal, so that's fine. It's just the other use of the word of axial that doesn't make sense to me. Anyway, the movement is a rotation around the y-axis. By convention, left horizontal rotation is a positive y, right horizontal rotation is a negative y. Right, so here we got a girl twisting, and her body's twisting like this, and it can only twist around the y-axis. It's best viewed from the overhead view, so it's horizontal. This would be left horizontal rotation. Another view would be right horizontal rotation. Now we get to this axial concept. And this was supposed to be invented to make things easy. To me, it just makes things more cuckoo. But nevertheless, it's out there. So the word axial was introduced to clarify the difference between translation and rotations in the horizontal and coronal plane. So when you hear the word axial, think of the y-axis. Right? That's kind of the axis of the spine. The spine is in this y-axis, so that's really what it means. Right? The problem, as I've said, though, the word axial is an AKA for horizontal, and but not coronal. So it makes it confusing. But let's see what they've done with this word. So axial rotation replaces horizontal rotation. Okay, I don't think you really need to do that, but nevertheless they did. Think axial as the spine, so that's pretty easy. So we just have axial rotation to the right, axial rotation to the left. It's the same as horizontal rotation to the right, horizontal rotation to the left. Okay, that's pretty simple. But this is the one I don't like. So axial translation replaces coronal translation. This is the distraction force and the compression force. So this is confusing. Biomechanics had trouble with this word, coronal translation. They just have to remember looking at this movement from the front, and if they can memorize that, it'll be fine. But nevertheless, they didn't do this. So it's the sliding of a vertebrae up and down the coronal plane, or the y-axis. And many decided to get rid of that word, and now they call it cephalad and caudal axial translation. Axial translation, right? And that's just nothing I can do about it. That's just the way it is. right? What about cephalad and caudal? They started having trouble with those. I mean, that, to me, it seems, I guess because I teach embryology, I'm used to those words, maybe. They have trouble, but they had trouble and confusion with regard to cephalad and caudal. So to overcome that, they use the more colloquial terms, the more common sense terms. They call it this. They say cephalad coronal translation. No, no, no. Let's replace that by upward coronal translation, or more appropriately, distraction. Distraction is the word you're going to use clinically. Okay, let's do some distraction on his low back, distraction on the cervical spine. Caudal coronal translation was replaced by downward coronal translation or compression. What about flexion extension? Okay, watch out. I probably should have put more stars on this slide. So flexion and extension is a clinical term that means the entire lumbar spine is flexed, or the entire spine is flexing. Flexion extension doesn't apply to a single motion segment. You have to use the word sagittal rotation. Anterior sagittal rotation is flexion. Posterior sagittal rotation is extension. Okay. Why? Because flexion and extension are not pure motions, and they're a combination of many motion segments. So you shouldn't talk about a single motion segment as being flexed or extended. It's always sagittally rotated. All right. So that's it for spinal anatomy. I hope you enjoyed it. I'm really sorry I couldn't be there in person. It's always, I think, better to be there in person, but nevertheless, you have a nice set of lectures. I'll leave these up forever, and you can, when boards come, it'd be really easy to go back to these lectures. It won't be easy to, I think you lose access to the virtual classrooms. You won't have access to those. These you always have. All right, we will see you probably in 5th quarter. I'll see you around campus.